All right, I have broken things down into 5 basic organ segments. I know there are a lot of them. I told you 3 years I've been working on this. Okay, but I also put some icons in so that you can see some basic facts about every case. So 37 of the 50 cases we will look at are motor vehicle collisions, and that will be designated with that green triangle. The other causes, well, we have the typical guns and knives. Actually, that's not a knife, it's a screwdriver. We have a soccer mishap, and then we've got a bull, a horse, a doctor, and a woman. So those are the potential, the sources of these traumas. I also went to the National Center for Biometric Information and pulled the expected mortalities for every one of these injuries. So you'll see that with each one. And then whether or not the patient lived is certainly an item of interest. So a deceased patient will be designated with that ghoulish skull icon. And then whether the radiologist actually made the call or not. Did they see the finding? That'll be a red X if the radiologist missed the finding, like Miss Othmar used to put on your grade school tests. So what this ends up is we have iconized all these things for every one of these entities, and you'll see those at the bottom of the screen. So if you ever think, hey, did this guy make it? You just look to the bottom and you'll be able to see the icon. All right, a minimal aortic injury. These are not so bad. As you can see, 5% mortality is all that's expected here. So they are not nearly as severe an injury, but they can be very difficult to see. This one actually came to attention through that stranding, I think would enable you to see it. Note that density around the aorta. You know how we actually found this? It was one of the first cases that AI pulled from the stack. We had an aortic dissection algorithm running, and it pulled this one, which is very interesting. So there is a little bit of contrast sticking into the posterior wall of the aorta right there. It's really tough to see. We'll watch it on the cine. So watch the back side of the aorta right there. You see it? Whew. But you can see that stranding all throughout. This patient had gone home. They brought him in and did follow-ups, but he was fine. This actually did not progress. All right. This one is an aortic laceration with hemopericardium. It's dramatic. And the thing that I like to point out about this one is you love to find the vector of any, especially with invasive trauma. You love to find the vector through the soft tissues, right, or through the lung, as in this case, and then follow it and predict what other structures might be injured. That's a bad idea. It's a bad idea. You can do it, but don't let it tunnel your vision, right? Because I have fallen into this trap, and this one is actually one that I saw and did fall into this trap. So there is extrathoracic gas. You can actually see the contrast extravasating here from the anterior aspect of the aorta. Look at the size of that hemopericardium and look at the compression of the ventricles. This is clear tamponade, right? We've even got contrast backflow into the hepatic veins lower down, and that is a relatively hyperdense pericardial effusion. But look at the gas, the extrathoracic gas, as well as a left pneumothorax, and look at that tract. It completely misled me. I have a screwdriver at the bottom. The guy who was stabbed said it could have been an ice pick. He wasn't sure. But anyway, I was looking at that. I saw that tract, and I said, clearly, this hemopericardium is from the pulmonary artery. And I spent minutes windowing that just to get because as you could see, there's a lot of contrast in the pulmonary artery. I was windowing it and looking everywhere. I just couldn't see where was the pulmonary artery injured. And of course it wasn't. It was all aortic the whole time. So I did ultimately, thankfully, find it. This guy went to surgery so quickly, I read his follow-up chest x-ray, his post-operative follow-up chest x-ray during the same shift. And so he actually made it. But that's a great lesson on the potential distractor that some of these injury vectors can create. And there it is. All right, well, this one is crazy, and it's another example of the same thing. You can see there is extrathoracic gas here. This one came in, by the way, with a clinical history of pellet gun, which is kind of distracting or misleading in and of itself. So when we go lower down, there's a lot of mediastinal stranding, and that absolutely has to be explained. There is a tiny little flap on the backside of the aorta. At first, it looks like it's an artifact, but I've been over it and over it, and it actually isn't. Now, the funny thing about this was one of the first QAs I ever saw. I was on the QA committee, so this must date 2005 probably. And one of the first cases they ever asked me to review was this one. And I looked at it, and the radiologist had reported on it and said, no pellet is identified, but there's so much hilar calcification it might be hidden. That's unlikely if you're really looking for metal. But this patient happened to have had a whole body lateral view scout. And there it is. And by pellet, they meant BB. I always think of those as BB guns, but this is what they had meant. This patient was shot in the chest with a BB gun. When I looked at this, I thought, thank God for that brilliant tech. The tech is omniscient, prescient, clairvoyant. How did they know? Right? And I called it in and said, you know, I agree, this is a BB embolism. How did your tech know? And they said, there was a foreign body implied by the history, and it's our standard to do a full body lateral scout in that case. So it actually wasn't the genius of the tech. But they did adhere to an intelligent protocol, that's for sure. So look at the direction that tract, that gas tract was going in the left pectoral region. It's headed off in a completely different direction, and probably the patient's arm was up like this when they were shot. So they never did anything with this. They just watched it. The surgeon said, I'm not going in there. It's going to be a pinhole on the front side of the aorta, and that back flap is going to tack down. And so he was probably right. They did not ever have to intervene on this patient. Oh yeah, they definitely are involved. You can actually see, in fact, I remember looking at this case as I scrolled down in, I said, there's density around the carotids, and it actually caught my eye. It was the first thing that caught my eye on this case when I looked at it. You know, Jim, you were the one that told me not to put arrows on things that just don't matter as much. And so I modified my whole style. I think there was probably an arrow on that when I first did this. All right, lastly, this is one from Kenny Hertz. It's fairly recent. This is a cardiac laceration where this patient is just blown out his right ventricle on the anterior side of the right ventricle, right up kind of towards the outflow. And in fact, lower down, there's another one right at the right ventricular apex. So this patient took a very hard blow right on the front of the chest. This was a snowmobiling injury. This guy hit a tree while snowmobiling with his buddies. And they always say, I ride a motorcycle, and they do always advise you to never ride with strangers. And I rather suspect, because if you're riding with strangers, the odds of you being with a suicidal idiot go disproportionately high. And I think that's probably what happened to this guy. So this one actually came through fairly recently. This patient did not make it. The thing that I thought was so interesting from an imaging standpoint is, look at this. The extravasation from the outflow portion of his right ventricle is actually leaking into a sternal fracture. And so he was strapped onto a board, and that was literally keeping that blood in place. It's pretty dramatic. And you can see there's the leak from the apex of his ventricle as well. So I called this, the clinician. I got the ER guy that saw him, and he said, yeah, this guy was talking and seemed to be just fine. They transferred him very quickly. But the guy I talked to, he said, yeah, when I called the receiving facility, they said, sounds to us like we're going to be on the receiving end of a corpse. And so they were correct. You can actually see that strap that they were using to hold him down, pressing on the front. There it is. So, and there is a nice view of the sternal fracture. All right. It's a cardiac laceration. Incredibly, I have a few of those. All right, let's go on to trauma through the rest of the thorax. First one is an aortic pseudoaneurysm, but with an esophageal rupture. So here, of course, is the aortic pseudoaneurysm. It's a little lower down on the thoracic aorta than you typically will see, but bound by adventitia. And that adventitial binding of that extravasated contrast is the only thing that's separating it from this mess of fluid and gas that's otherwise occupying the mediastinum. And here it is, again on the coronal, and you can actually see that collection of gas and fluid. The esophagus just tapers down into it. On the axials, you can see it nicely. There is the aortic pseudoaneurysm. Now we'll go through it again, and you can track the proximal esophagus going into that collection of gas and fluid, and then you'll pick up the esophagus coming out of it. So that whole middle section is just macerated and exploded, essentially. It's an interesting thing that you usually don't get widespread mediastinal gas with a traumatic esophageal rupture, right? With the Boerhaave syndrome, Mallory-Weiss tears, and that sort of thing. If you think about the ones you've seen, there's usually gas all throughout the mediastinum, right? It gets everywhere, typical pneumomediastinum. But with an esophageal rupture from trauma, supposedly the tissues are expanded so rapidly that they knit together and encase that, and will typically keep the fluid and gas in a single compartment, essentially. All right, and there again is that aortic pseudoaneurysm. The other thing I noted, we've got 33% here. I take the middle, but with all GI ruptures, that they are the most time dependent in that the mortality takes jumps with every 8 hours of delayed diagnosis. Right, so when you look at esophageal, if you get it in the first 8 hours, it's really down around 16% mortality. Right, if you get it in about 16 hours, it'll be 33%. If it's delayed by 24 hours, that mortality is closer to 50%. So that's true through the esophagus, stomach, and small bowel as well. Less so in the small bowel, but duodenum. All right, this one is just a very interesting, strange vector, I can only assume, where this patient's chest was compressed and it blew out the lateral aspect of his aorta. This is a strange place to see an aortic laceration. And again, it probably expanded the pulmonary parenchyma so abruptly that it kind of compressed it and kept that extravasated contrast all together in one place. You can see the vector. I like this because you can tell that's contusion from a blow to the anterior left chest. It's not distributed peripherally, concentrically around that pseudoaneurysm to suggest, which would suggest that it's actually aortic hemorrhage we're looking at. So I believe that's probably a pulmonary contusion that we're seeing because, again, it's directional. Again, that's just a very unusual place to get an aortic laceration. All right. So this is a case of diaphragm rupture. It's obviously it is associated with an aortic tear as well. I have 3 cases of left diaphragm rupture combined with aortic lacerations. One of them was properly diagnosed, both the aortic laceration and the diaphragm rupture. In one of them, the diaphragm rupture was called, but not the laceration. In the other, the laceration was called, but not the diaphragm rupture. All right, so this is a combination you may very well see. So here you can see the stomach is elevated, the NG tube helping you to determine that that is in fact stomach up in the left hemithorax. And here is the spleen, which is showing a peripheral, well-circumscribed subcapsular hypodensity, suggesting there is an upstream vascular injury. In fact, and you can see this is the diaphragmatic defect right here where the stomach is coming up through the diaphragm. And in fact, you can see these same peripheral wedge-shaped hypodensities in the kidneys as well. So if somehow you missed that aortic laceration, you still should have your attention called to it by the presence of those splenic and renal abnormalities. So there's that aortic laceration. And here's the stomach up in the left hemithorax, and there it's wasting, right, going right through a smaller diaphragmatic defect. There's actually a liver laceration, and then again, those splenic abnormalities and the renal ones. This is particularly nice actually on the coronals, but here's the sagittal. It shows that aortic laceration very nicely with a big flap. And then here are the coronals. You can see the laceration. This is colon and a little bit of stomach up in the left hemithorax, and you can actually see the defect in the left hemidiaphragm, which is nice. You don't always get to see that. Left is much easier to diagnose than right. And look at that. When I first looked at this, I said, oh, his spleen is upside down. But actually it's not. It's rotated about 90 degrees though. I went and looked at all the other planes and it's not quite upside down. But it's pretty neat that you can see it's sitting above the remaining leaf there of the left hemidiaphragm. And look at those kidneys. You really can appreciate those peripheral wedge-shaped microembolic injuries right there. That's one looking at. You can actually see the defect in the diaphragm, the stomach and colon going up through it, and the upside down spleen.